All right, so today we're going to start talking about intrapartum care. So this will be care during labor and delivery. We'll start with some of the processes that happen during labor and delivery and then move on to some of the nursing care. The first thing we have to think about as far as what happens during labor is what are the things that happen that would identify that somebody needs to come to the hospital. And this kind of ties over from the antepartum information that we were finishing up with. So if someone believes that their water broke, now at times it's not always that their water broke. They could have some leakage of urine, but it is best to get that checked out. Frequent and regular contractions. So this means that they're getting closer together, they're getting stronger, those kinds of things. If they're infrequent and they're not regular, you can't really time them. Those would not indicate that you need to come to the hospital. Those would be more like Braxton Hicks contractions. Any bleeding, vaginal bleeding, would be a reason to come to the hospital, as well as that decrease in fetal movement like we've talked about earlier. When we think about labor and delivery, there's 5 factors, or the 5 P's, that we have to consider as we think about this. And we're going to talk about each of these 5 components separately. The first P is the passage. So the passage is the true pelvis. So as we talked about before, you've got the false pelvis and the true pelvis. And the true pelvis is the one that the fetus has to pass through during delivery. So you want to think about the inlet, which is the top, the outlet at the bottom, as well as that mid pelvis, as you can see on the picture, which is kind of right between those ischial spines. In addition to the passage, we have to think about the passenger, in this case the baby. And there's a few things we have to think about with that passenger. So what position is the head in? Is the head in, is it head down? Is it head up so that it's a breech presentation? Where is that head? The bones of the cranium are not fused, and this allows for movement as the infant passes through the pelvis. So there's some molding that occurs in a normal delivery, and you can see over on the far right side in that complete extension, you can kind of see that that infant has some molding on the head. So that's kind of what we're looking at. It kind of comes to a narrower diameter so that it can more easily deliver. These fontanelles, there's 2 that we really want to think about, the anterior and the posterior, and those are things that we'll come back and we'll talk about again when we discuss newborns. The fetal attitude, so this is what position is the baby in as far as their relationship of their parts to one another, so their posture, essentially. And what we normally see for fetal attitude is complete flexion. This is a normal position and is good for delivery. And then as you kind of go across over to complete extension, you see that instead of the occiput being the presenting part, if you were to imagine that that baby is preparing for delivery, you see that it's kind of heading more towards the forehead, the brow, and then a complete extension where it's a face presentation. So the complete flexion is the normal one and the one that we would want. Some additional components we think about with the passenger is the fetal lie. What is the lie? Is it longitudinal or horizontal? So longitudinal or transverse would be another way to think about it. Longitudinal would be either a cephalic or head down presentation like you see in that picture, or it could be a breech presentation, would still be longitudinal with the head up. Transverse lie, on the other hand, is where the baby's laying crossways or perpendicular to the long axis of the mother. Now, fetal presentation can be a variety of things. So in that cephalic presentation or head presentation, you have the vertex, military, brow, or face, and those correlate with those 4 components on the previous slide related to the if the baby is flexed or extended. If they're in a flexion, there'll be a vertex presentation, the occiput will be presenting. If they are in full extension, the face will be presenting, and then the military and brow are those 2 in between. For breech presentations, so this is where the head is up towards the mother's ribs and the bottom is presenting, there can be a couple of things. A complete breech It's essentially if you take that picture there with the longitudinal line and you flip it around. So the baby is still in a flex position, the legs kind of curled up, and the bottom is presenting first. A frank breech, on the other hand, the legs would be straight up. So instead of them kind of being in that flex, the legs would be straight up and the toes would be up by the ears. And then a footling breech. And a footling breech means that the legs are pointing down, and the legs then would come out first. And that could be either a single footling with just one leg down, or a double footling with both legs down. So a few different positions to think about. The frank position is very notable after delivery because the legs tend to want to stay up in that position that it's been in because they've been way up by the ears. The shoulder position is that transverse lie. That's the only way that the shoulder would present first. So that would be only occur if the baby is in that position. And we're going to work on some of these in class to work on how these positions look. So position, and so we went passage, passenger, and then we look at the position. So where is baby in the maternal pelvis is what we're looking at there. So engagement occurs when the largest diameter passes through the pelvic inlet. So the baby has entered into that true pelvis. This can be determined by vaginal exam. So prior to engagement occurring, the baby is going to be ballotable. So if a provider does an exam and palpates, the baby's head would kind of bounce because it hasn't engaged. It's not kind of stuck down in that pelvis to start working its way through. Once it's engaged, we measure station. And station is measured as a relationship to the ischial spines and the presenting part. So a 0 station is at the level of the ischial spines. And you can palpate those during a vaginal exam. And then plus or minus centimeters above or below is how we judge station, depending on if baby's high. So you can see in that picture here on this slide, baby's at probably like a -3 station because there's a little bit of head that we can't see there in the pelvis. And as baby comes down, you could see that +3, +4, and it even goes into +4 and +5. That's getting closer to delivery. We also look at position in relationship between the passage and the passenger. So this tells us what is the what position is baby in. And so we look at 3 different components to come up with some letters that represent this position. We look at the maternal side, whether it's right or left, the landmark of the presenting part for baby. So this is what part is baby presenting with, and you see some options here. So you have the occiput, you have the mentum, the sacrum, or the acromion process, which would be the shoulder. So head, face, breech, or shoulder presentation are all represented within those letters. Maternal landmarks then would be where is that presenting part in relationship to mom again? Is it right or left? And then is it anterior, posterior, or kind of just straight transverse? And again, these we're going to work on in class and kind of get our hands on to really demonstrate. And you would put these together to then come up with a clear indication. So you might see ROA, which would mean the baby is right occiput anterior. And this is a good position for delivery. If you have a baby that is either right or left occiput posterior, that mother's going to experience more back labor. The baby would be born facing up instead of facing down. And there can be some challenges. And then again, all those combinations thereof. Occiput anterior is the most ideal position for labor and delivery. So that is the one that we really want to see baby in. The physiologic factors that relate to the 5 Ps are the contractions that occur, and those can occur spontaneously or induced, and then also the bearing down of the mother at the time of delivery to help assist with delivery of the infant. Psychosocial considerations relate to much of the fear or anxiety of the unknown. Could be related to a bad experience they've had previously, and then additional fear about this birth. This can, many patients will then decide to write a birth plan, and think about how they want their labor to go, what they do and do not want. One of the things as nurses and providers that we want to be sure of, well, we want to honor the patient's wishes. We also have to be realistic that sometimes things are unpredictable and plans may need to change. So having some flexibility if needed to do those. One of the major psychosocial considerations is that a support person, or persons, as you see in both of these pictures, tends to have a very positive effect on labor. It decreases that fear and anxiety. So having somebody to talk you through, whether it's a partner and then also the nurse in both of these. So you can see that in these pictures, that support person is really hands-on in helping these moms through some of the discomforts of labor. So in this next part, we're going to talk a little bit more about the physiology of labor. And again, like many things that we've talked about in this course, we don't know why labor starts when it starts. There's lots of theories surrounding why labor starts when it does, but we don't really know exactly why. Well, let's talk about what we do know. What happens to the uterus during labor and delivery? The uterus divides into two distinct portions. So the upper portion, up by the fundus, is the contractile segment. So this becomes thicker as labor progresses. And that's where you're going to palpate the contractions, and you're also going to note the measuring of the uterine activity as the belt will be placed in that area as well. The lower segment, on the other hand, thins and expands to open up to allow for the fetus to pass through and out of the uterus. And in the picture you see that when we look at dilation and effacement when we're measuring these. So dilation is the opening up. So how far open is it? And it's measured from 0 to 10 centimeters. And effacement is how thin has that cervix become. And we look at that from 0%, which is not effaced at all, not thinned out, to complete effacement, meaning it's completely thinned out and ready for delivery. So at the time of delivery, we want at the time that pushing starts, we want complete effacement and complete dilation, so 10 centimeters and 100% effaced. The pelvic floor is also drawn up, and the perineum thins from around 5 centimeters to 1 centimeter in thickness to also allow for delivery. And we're going to work on some of these things in class as well to kind of help to solidify these terms. Some of the premonitory signs of labor. What do women maybe experience that tells us that labor might be starting? Now, these are premonitory. It doesn't tell us when labor is going to start, but there's some of the things that women might experience. So we're going to start at the top here. Lightning. Lightning, or dropping, is when the fetus engages into the pelvis. So this sometimes happens in primips, or women who are having their first baby. It can even occur a couple weeks before delivery, but for small tips who are having second, third, fourth, or so on, this might occur even right at the time of labor. But you notice sometimes when that lightning occurs, women will know that baby has engaged. They will have more pressure on their bladder. So some more bladder symptoms that have occurred. But because the baby has dropped down a little bit lower into the pelvis, often the shortness of breath they might have experienced because of the pressure on that diaphragm is relieved a little bit, and they can breathe just a little bit easier. So a positive and a negative that is experienced as that occurs. They may notice some more Braxton Hicks contractions as that uterus is preparing for labor and delivery. Cervical ripening is another important aspect. So the cervix doesn't do all of the dilating during labor. The cervix during pregnancy is very firm, and it's a tightly closed component so that it can maintain a healthy pregnancy. But at the time of labor and delivery, it needs to completely efface and dilate, like we talked about on the previous slide. But first, we have to think about, is something firm going to be able to thin out and dilate? And it really doesn't do that well if it's firm. So there's some cervical ripening that occurs naturally in those later weeks of pregnancy that has some softening. Some of the effacement starts to occur, and often some of the dilating, so that when a woman goes into labor, it's just finishing that effacing and dilating. So cervical ripening is really, really important to ensure that that cervix is ready to respond to the contractions during labor. Bloody show, so this can be a sign of impending labor, and this occurs when a woman loses her mucus plug. So this also kind of happens as a result of some of that cervical ripening. As that cervix starts to efface and dilate, that mucus plug that was blocking the entrance there to the cervix, it loosens up and it comes out because of that thinning and opening that's going on. Rupture of membranes, and often we wonder why this would be a premonitory sign of labor, because doesn't that mean that labor started? And it doesn't, because rupture of membranes just means that the water broke. Labor is the onset of contractions and that contractions are occurring. So rupture membranes, about 12% of the time, will rupture prior to labor onset. And that can be a concern because maybe it happened and the cervix isn't ripe. Maybe if she's not contracting, we worry about infection if labor takes too long after the rupture of membranes. So it's really not the best way to get things going, because then we have to get things started to decrease the risk of infection. Nesting. So nesting is that sudden burst of energy, putting everything together, getting the house clean, getting the baby clothes all ready. This one you often probably have heard about. There may also be some weight loss, as there's some fluid shifts and GI symptoms such as diarrhea, indigestion, and nausea and vomiting that can be seen during the weeks leading up to labor onset. True labor versus false labor. This is another thing that we really have to educate women on. So how do we know what looks like true labor or false labor? So often the contractions feel a little bit differently as to where the pain begins. But more commonly, the big things that we look at are the bottom three. In true labor, the contractions are going to intensify. They're going to get stronger. They're going to get more frequent. And they're going to cause changes to that cervix. Whereas in false labor, the contractions are going to stay the same. They're not going to get stronger. They're not going to increase in frequency, and they aren't going to cause any cervical changes. So those are really what we're looking for as far as deciding, are these contractions labor, or are they false labor and just some Braxton Hicks contractions as the body's preparing? So we really have to monitor and time those to really be able to make that decision. Once a person has gone into labor, we do break labor down into various stages to define where they're at within that process. And there's 4 stages for labor. The first stage is all of the dilating. So this is actually broken into a few phases, and we're going to talk about each of those. And then the second stage occurs once the patient is completely dilated. The second stage begins, and it goes from full dilation until the fetus is born. And then the third stage is from the time of delivery of the infant until the placenta is delivered and expelled from the uterus. And then the fourth stage is the first 1 to 4 hours, kind of right after delivery, as some of the initial shifts and recovery are going on within the body. First, let's talk about the first stage. So the first stage is broken into 3 phases, like I had mentioned: latent, active, and transition. So latent is often, you might hear early phase as well. So the latent phase is really it's the longest. It takes a while. There's maybe some irregular contractions. They're mild. Sometimes this is hard to differentiate from false labor because things aren't quite picking up pace yet, but maybe this is it. Maybe it's real. Maybe this baby's coming. So it tends to be very exciting for women during this time. You'll see on this slide, and this matches what's in the book, that historically we've said that the latent phase is 0 to 3 centimeters. However, this is now, this definition is now changed, and you'll see on your PowerPoint too that you've got a link to an article. We now differentiate early versus active labor by looking at when did things become more regular, because that really defines it. If you think of early versus active, latent means, you know, it's latent, things are just kind of hanging around, but then active is active. So when did things become more intense? So we really don't define it based on centimeters at this point. We really look at more what's going on. So nursing care during this stage. You might be talking to the woman about timing her contractions, about making sure that she's resting or walking around, that she's working on getting things ready, that she's got her bag ready for the hospital if she's not already there. And just really preparing for labor, making sure that she's getting herself ready for the more active phases and the labor component that's going to happen. The active phase, this is when we want women to be at the hospital. So this stage tends to last about 3 to 6 hours, so it's a little bit shorter. And again, we don't really measure it from 4 to 7. We're really looking at when did things become more active, and we look at it during these moments. So regular strong contractions would indicate that they've entered the active phase. So as these contractions became regular and stronger, they might also have some increased anxiety and increased pain as a result of that. This is a good time for analgesia, whether it be an opioid type of medication or through the IV or IM, or if they choose to go with an epidural, this is a good time. If we give it too early, it can stall labor out. But once we've got good, regular, strong contractions happening, then it's a good time to initiate some of that type of management. And then the last part of the first stage is transition phase. So transition is the shortest phase. This occurs usually, and this is right at that tail end. So the last couple centimeters dilation is the transition phase. Women, usually this is the shortest, so it can be less than an hour, and there's strong contractions. This is when they start to feel some rectal pressure. They may start to feel an urge to push and additional anxiety. They also are more at risk for hyperventilation because of the increase in strength. They might get hot, they might be angry, emotional, they might be sensitive to touch. They do need a lot of support during this stage. It's a very intense stage. They may have some nausea, vomiting, or crying during this stage. So very emotional, very high anxiety, and need a lot of support. And this can be kind of scary sometimes for partners, especially if they're not have not been in a labor and delivery room before. Sometimes this intensity of this phase is difficult. The second stage of labor is what we generally talk about as the pushing stage. So the pushing stage goes from 10 centimeters until the baby's born, and this can last anywhere from 30 minutes to 3 hours for the first baby. And there's some cardinal movements that the baby's going to go through during this phase, during the second stage. So they're going to descend into the pelvis. They're going to have some flexion, internal rotation, extension of the head, and then restitution. And then external rotation occurs once the head is delivered. The head is going to turn after the head is external. And this allows for the shoulders delivery, which results in expulsion. We're going to watch a video on this in class to kind of show that. The one thing to think about here, for those that have seen a delivery, during that external rotation, we often see that the provider is supporting that head of the infant. So it looks as though the provider is turning the head, but in reality, this occurs naturally on its own to allow for delivery of the shoulders. And there are some pictures in your textbook that you could look at that also indicate these. Some other things we want to think about during this care. What is your role as the nurse? So the nurse is a support person, helping that mother get through this component. Thinking about what kind of positionings are going to facilitate delivery of this infant. And you see the top picture there, that's what we typically picture for delivery. And is very, very common in our society. However, it's not necessarily the best one for pushing and delivery because it doesn't open up the pelvis. If you look at the bottom one, she's got her leg kind of kicked back. She's using that towel. So as she pulls on that towel, she's going to naturally bear down. And that leg being up is going to allow her to open up her pelvis a little bit. And that's just one example. There's a variety of other positions and things that women can do that help to not only open up that pelvis so that baby can get through, but that also helps with some of those cardinal movements and those twists and turns and things that the infant needs to do on their way out. Then the third stage. So third stage occurs after delivery of the infant and until the placenta is delivered. And this occurs shortly after delivery, only lasts about 5 to 30 minutes. And we watch for signs of placental separation. So placental separation is indicated by things such as a gush of blood as it separates, because you see then there might be some bleeding from that site. The cord will lengthen, so there might be some slack then in the cord as the provider is watching for that. The uterus will rise up anteriorly, it'll become firm, and then the woman sometimes will even feel an urge to push. So she will push, and it's a much easier delivery, obviously, because it's much smaller than the infant, and the placenta will be expelled. Nursing care during this time, you're really monitoring vital signs very closely following delivery of the infant, and you're watching for time so that we see that it's happening in a timely manner. We have the fourth stage. So the fourth stage has some bonding, some recovery, and physiologic readjustments going on. This is a very, very important stage. However, not often thought of as a stage of labor. The first three tend to be, once that placenta's out, labor and delivery are over. However, we really want to look at some of the key things that are happening in the first 4 hours after delivery. So things like making sure that the infant's doing well, that they are adjusting to life outside the womb. This is a perfect time for skin to skin with the mother. Many hospitals will practice a golden hour policy. So the golden hour really reflects the importance of that bonding and that time for skin to skin and establishing breastfeeding during that immediate postpartum time frame. And so in that golden hour, the hospitals that utilize that practice don't allow visitors until that hour is up, because it's so important to allow this fourth stage to happen successfully. Some other things that we want to think about are identification, making sure that the infant gets matched up with the bracelets matched to the parents. We're going to do assessments on mom, vitals, looking at blood pressure and pulse primarily, as well as the amount of lochia or discharge, vaginal discharge that she's having. Is the fundus firm like we would expect after delivery? We'll look at think about her bladder, is she emptying, and then look at her perineum. So we'll talk more about those types of assessments when we do postpartum in a few weeks. But again, we're really monitoring her closely for all those changes that occur postpartum, and then giving her some time with the infant. So what kind of responses happen in the maternally following are due to labor and delivery? And we're going to talk about these by system. There's several systems that have some responses to labor and delivery. So cardiovascular system, you see that there's a resting pulse increase, and that makes sense because there's labor going on. An increase in cardiac output, and then an increase in blood pressure also as a result. And none of that really surprises us when we think that the body is in labor, and labor is labor, it's work. So those are naturally things that are going to occur. The fluid and electrolyte balance can be a little imbalanced, and that really relates to some of that hyperventilation and perspiration that occur as a result of the labor and the pain that's going on as well. In the respiratory system, we see an increase in oxygen demand and consumption, an increase in respiratory rate, and then there is a risk for some problems with acid-base balance as a result of that hyperventilation. So thinking about that as well to monitor for that. Renal system. In the renal system, there's some polyuria. We do see some higher urine production during labor, and there is a possibility for some hematuria if there's any bruising or anything like that of the urethra. And then during that in the gastrointestinal system, we see that there's some reduced motility and absorption, and that really relates to the labor that's going on, the movement of the fetus, and those things that are occurring. Decreases that peristalsis, decreases gastric emptying, delays it a little bit. So there is a risk for aspiration as a result of that change in the gastrointestinal system, which is why it can be a common practice to avoid food during labor because of that risk for aspiration and as a result of decreased emptying time. Immune system, or not decreased emptying time, sorry, prolonged emptying time. there is some increase in the white blood cells, and the blood glucose levels are going to decrease in labor. So as a result of the work that's going on. So the same as glucose levels decrease with exercise, they're going to decrease in labor. So that's important for women that have some alterations, or maybe that were diabetic. Their glucose levels are going to decrease. Their insulin needs are going to change during labor. Nursing assessment. So what are the assessments that we're going to do as nurses to during labor and delivery? So temperature is usually about every 4 hours that is taken, or hourly once the membranes have ruptured, because then we've increased that risk for infection. For blood pressure, pulse, and respirations, for low-risk women in the first stage of labor, these can be done every 30 to 60 minutes. But if they're high risk for any reason, they would do them more often, like every 15. In the second stage of labor, they might be every 15 to 30 minutes in low-risk women, or even every 5 minutes in high risk during that pushing time frame. So often this results in an automatic cuff, maybe on those, for those very frequent vitals. We're the nurses providing support. We're looking at comfort as a big thing, helping with position changes to facilitate labor progress, and reducing anxiety in the mother. So anything that we can do to help reduce that as she's going through the process. Checking for progress in dilation and effacement with a cervical exam, and you can see that in the picture as an example. And we're going to demonstrate how that's done in class as well on a model. And then measuring contractions, to monitoring those contractions for strength and frequency, to evaluate labor status and how things are progressing. In the second and third stage, we're also assisting with delivery of the infant and the placenta. We would be monitoring for any need for Pitocin infusion and looking at the APGAR score as well on the infant. Upon admission to the hospital, we would be monitoring lab work. So the woman will likely have a CBC done, so we're going to need to look at any signs of that for infection. Also looking at the platelet count in case she would want an epidural. The platelet count needs to be normal. Type and cross is commonly done in case blood would be needed later on. And the HIV test, if it was not done previously in the pregnancy, that might be done at this time as well. The other thing that we do during that second stage is we really allow for spontaneous pushing. So we're going to assist with pushing and encourage pushing, but we're not going to tell her, okay, at the peak of this contraction, you're going to start pushing, and you're going to push for 10 seconds and take a breath and then push for another 10. That's previously been something that's been done, but we found that if we wait and let the mother really go with her natural instinct, that it's a better success and results in less maternal fatigue and some other things. So better labor and delivery experience. So how do we time contractions? Because that's one of the key things that nurses are doing. So we're going to palpate the fundus of the uterus, and we rate them as either mild, moderate, or strong. So remember that that external monitor it's only sensing the pressure placed against it, and there's a lot of things that can change how that might feel. And so we really are only looking at the strength of the contractions by palpation if there's an external monitor. So we're looking at mild, moderate, or strong is how those would be documented. And you can see right there, mild is going to feel like the tip of your nose. Moderate is going to be like your chin, whereas strong is going to feel like your forehead. And do that so you can kind of see, because that truly is how we differentiate those strengths of the contractions. Duration of the contraction is looking at how long does that contraction last. And the ones in the image here on the slide last 60 seconds or 1 minute from beginning to end. And then frequency is beginning to beginning. So when from the beginning of one contraction to the beginning of the next. And you can see on here that they're 5 minutes apart. So we're always looking for frequency when we talk about how often are the contractions occurring versus the time in between, the rest time in between. Another area that nurses are working with is helping the woman as far as a pain perspective. And there's many different perceptions of pain. Some women will experience a lot of pain and others will not, because we all experience pain differently. It's very subjective. Some of the things that might contribute to pain sensations are things like the dilation of the cervix, the hypoxia of the muscle cells during the contractions, stretching of that lower uterine segment, and then the pressure on adjacent structures such as the back. And you can see here where the nerves are. They're in the thoracic and lumbar area that experience a lot of these sensations. So another area where we really intervene is in pain management, and we're going to talk about the different things that we can do to help as nurses with pain management. So we want to switch that fear, tension, pain cycle to conscious breathing or other interventions that allow for a more relaxed state that then reduces pain. So the higher the fear and anxiety, the more complicated and intense the pain feeling might be. Pain management we can approach from several different ways. There's non-pharmacologic methods and pharmacologic methods. So the non-pharmacologic are really what we do. We encourage all throughout labor, but in that early phase, for sure, when we aren't really thinking that we want to do any analgesia yet, those would be primarily used. And then again, they're used really throughout to assist or even complement the pharmacologic if a female chooses to use some of the pharmacologic options. So we're going to talk about each of these separately. So the non-pharmacologics, so things like imagery or hydrotherapy, different things like that can be very beneficial in assisting with pain control. So slowing down breathing is going to be the first one. And you've probably heard of different breathing techniques or sounds that women can make, but really the technique is not as important as the outcome. The goal is to prevent hyperventilation. We want controlled breathing. That's the outcome that we need. So breathing with her, encouraging her to slow down, to focus on the breath, anything like that, just to prevent that hyperventilation or even breath holding that sometimes can occur. So we're really just looking at the outcome. However you go about that is fine as a nurse. The other non-pharmacologic things, so tubs or showers, and you see the whirlpool being utilized here. This is so common. That buoyancy relieves muscle tension. It can reduce the use of analgesia, and it can be very, very relaxing. So you can see it actually being utilized in that picture. And this is common. Most facilities have whirlpools or showers that women can use during labor. We even have the ability often to have waterproof monitors, so we're monitoring them while they're in there. You see then over on the other side, somebody looks like a pregnant woman kind of floating. This can even be, you can use the concept of buoyancy in an imagery technique to kind of feel lighter, to feel more buoyant, to relieve some of that muscle tension. And then some other imagery things or guided focusing kind of things. That middle picture with the flower, you can see that picturing a flower opening up, but that's really a head of a newborn delivering. So maybe just picturing yourself opening up can be an imagery that can be beneficial. Or having a picture of yourself with, if it's not your first child, a picture with an infant right after delivery that you have done this before, that you've been successful. That can be another image or focusing point that women can use. And then also the position changes. We're going to talk about those on this next slide. So position changes. Here's what we don't want a mother doing during labor. Lying flat on her back, or lying on the bed even with a slight left tilt. We want everything else, right? We want her squatting or rocking or kneeling with the birthing ball, or leaning forward in a chair, or sitting, or on her hands and knees, or lying on her side and then switching to the other side, walking, dancing, anything you can think of that's not just laying flat on your back, not opening your pelvis. So moving really helps to decrease that sensation of pain. So some of the other things that can work for labor also work in pushing. We could do a lot of these for pushing. Squatting opens the pelvis tremendously for pushing. A woman can squat using that bar that was in those pictures in the bed. She could push in hands and knees. So these are positions that not only would be helpful during labor, they can also be helpful during the pushing phase. Pharmacologic methodologies include narcotics, epidurals, or nitrous. So some of the nursing considerations surrounding these pharmacologic methods is monitoring vital signs both before and after the medication, looking for any contraindications. So I mentioned the platelet count would be if it's low, would be a contraindication for an epidural. So monitoring for some of those, thinking about other medications the woman might be on. Is the fetal heart rate normal? Are we is it reactive? Is there variability with no decelerations noted? If there's any of those things, that might not be the best option, because some of these will cross, especially the narcotics are going to cross and the baby will respond to those a little bit. Contraction pattern, or is she in active labor and things are moving along? So narcotics can be given oral, IM, or IV, but IV is going to be the most common. With all of these, you're going to be monitoring for respiratory depression, and they're often not given during that transition phase because delivery is very imminent. One of the things you have to think about, because those narcotics are going to impact baby, is that if delivery happens too soon after giving the narcotic, the baby might experience some respiratory depression. So thinking about having Narcan available, not just for mom, if mom would need it, but also it could be given to the newborn that maybe is born very quickly after administration of our narcotic medication. The epidural is very successful. For 85% of women, they have complete pain relief, but they often still feel a sensation to push. So it decreases the pain without getting rid of the pressure sensation. So allows labor to progress normally. It's a continuous block, so as you can see in that picture, the difference between a spinal and an epidural. The spinal goes into the spinal space where the fluid is, and the epidural goes into the epidural space. A spinal is a one-time shot, okay? So it's given, the medicine's injected, and then the needle is removed. Epidural, once that epidural space is located, a catheter is inserted, and so the catheter allows for continuous infusion. So during labor and delivery, this is the better option because we can't always predict how long it's going to last. During a C-section, if it's scheduled, the spinal block is sufficient because we would give it right before the operation started. Some of the side effects, obviously there's going to be some decreased motor function in the lower extremities, maybe a decreased sensation of voiding, so monitoring for the bladder fullness would be important. And then she is stuck in bed once that epidural has been given. Things you might have to do as a nurse. You may need to insert a straight cath or a Foley catheter to empty the bladder because of that decreased sensation. May need to monitor for some fetal malpresentation or slowed labor progress because of the decreased movement that's occurring. The role of the nurse during and after the epidural are things like, as you could see in the picture, assisting with position during and after. The mother needs to stay very, very still while this is going on, but she's still having contractions, so she's still very uncomfortable. So the big role of the nurse is helping to assist with that positioning and not moving during that. Monitoring the blood pressure very, very frequently. Hypotension is one of the primary risks for epidurals. So you can monitor the blood pressure every 1 to 2 minutes for the first 10 minutes. The other thing that happens to try to prevent hypotension is that the nurse is going to preload with IV fluid. So fluid bolus is going to be given before the epidural is ever inserted. Monitoring respirations is going to be important afterwards. And then monitoring for pain relief. Monitoring for that fetal heart rate, especially if hypotension occurs. That can impact that baby. And knowing that if she does become severely hypotensive, ephedrine would be the medication that would be used to counteract that. So fetal response. What is the fetal response to labor? Primarily, we would see some changes in heart rate as a result. There might be some acid-base adjustments because of the contractions and the pushing that's going on. But with all of these, that fetal and placental reserve should protect the baby during this time if everything is healthy. We monitor the baby during labor and delivery, and there's a few things we have to think about. How do we know where to put the Doppler or the belt so that we can monitor for that fetal heart rate externally? And there is a thing called Leopold's maneuvers, and it's talked about in your book. And we do this to determine which position baby's in, because we want to put that monitor over, and you can kind of see this, over the baby's back, and you see that in those pictures where those red circles are. So we will watch a video that demonstrates Leopold's maneuvers to determine positioning. Once that position has been determined, then the monitor is placed in an accurate position over that over the fetal back, and allows for monitoring of that heart rate. So you could see in this slide, it talks about both external and internal. And external is the most common. Internal is used much more rarely, but we're going to talk about why those might be done. So the external monitoring, it can be very helpful in guiding us to see that the heart rate is doing well, showing us what the uterine activity is as well. And we document these heart tones every 30 minutes in the first stage and every 15 minutes in the second stage for low-risk women. So similar to what we're doing the maternal vital signs. And then if they're high risk, it'd be every 15 minutes in the first stage and every 5 minutes in the second stage. Some of the things that we have to think about is, do they need to be on the monitor all the time? And in low-risk women, they don't necessarily need to be. We can hook them up just from time to time to meet those standards of documentation, but not necessarily leaving them hooked up entirely. But there might be some reasons. So if there's a deceleration or a concern in the contraction response rate, then we might need to monitor more continuously. There's also, we have the ability to do some internal fetal monitoring or assessment of uterine contractions. And you see here, the picture on the other side shows those components. The fetal scalp electrode is an internal fetal heart monitor, and so that attaches to the baby's scalp via an internal exam. And instead of using ultrasound technology, it actually uses the electrical conduction to monitor that. So it's a very, very accurate depiction of what that fetal heart rate is and what it's doing. So sometimes this can be utilized if are we concerned about the fetus? Are we not really getting a good tracing externally for a variety of reasons? So this might be used to give us a better picture. But you can't do these internal ones unless the water has already been broken. The other kind of internal monitor that's used is an intrauterine pressure catheter. And this, as opposed to having just that button that senses the pressure externally, this actually fills with fluid in this tube. So it's inserted and it kind of goes up into the amniotic fluid right alongside baby, as you can see in that picture. And it actually then it can measure the pressure inside the uterus that's exerted on that tube. So it's very, very accurate and actually gives us some numbers or some quantitative information regarding the strength of contractions. And again, these aren't used very often, but they are a possibility if we need a little bit more information about labor to make some decisions. So what are we looking for when we're monitoring for the fetal heart rate? And so there's three tiers that we look at generally. So category 1 is good. These are babies are doing well. They're doing what we expect to see them doing. Category 2 are infants maybe we're starting to worry just a little bit about, and then category 3 we're very, very concerned with. So you see in category 1 that baseline is normal. There's some variability. There's no decels that are late or variable type. There could be some early decels, but again, those we're going to talk about as normal. And then there could be some accelerations. In number 2, we might see reduced variability. We might see some decelerations or bradycardia. And then in category 3, there's no variability or recurrent decels, or a sinusoidal pattern that we'll demonstrate for you when we do more of this in class. So to determine what are these decels and what do they mean, when we were monitoring for them. So we had talked about those late decels when we talked about the contraction stress test. But there's also early decels and variable decels. So we'll look at the term VEAL-CHOP. So VEAL-CHOP is a good acronym if you line it up. So the V would line up with the C, the E with the H, the A with the O, and the L with the P, and write it next to each other. So VEAL, the V would stand for a variable deceleration, and that lines up with the C of CHOP and tells us that the variable deceleration relates to cord compression. So cord compression can be just positional, that baby's in a position they're kind of pushing on the cord. These are random. They don't always correlate with contraction like you see in that picture. Sometimes they just happen. Maybe baby grabbed a hold of the cord and squeezed it. So these are not always concerning, but we want to kind of monitor them and see if we can ensure that we can resolve them. The E is early decelerations, and that lines up with the H. So it's due to head compression. So early decelerations, they start at the beginning of the contraction as opposed to later in the contraction, and they end with the contraction. And these are a result of squeezing of the baby's head, which we expect to occur during delivery. So these are not necessarily concerning because that head compression is expected. The A of VEAL would stand for accelerations. So the O then is optimal because we do want these. And then the L is late decelerations. So late decelerations, like we talked about before, are due to the placenta insufficiency. So that L lines up with a P to tell you that late is due to the placenta. Nursing care. So what are we going to do for some of these? Early, we're going to continue to monitor. We're going to continue that pushing stage as long as they continue to recover and look healthy in between. Late decelerations, we might put her over on her side, make sure that that placenta is getting the perfusion that it needs. Maybe giving some additional fluids or oxygen to try to do some intrauterine, resuscitation. So helping that fetus the ways we can by increasing placental perfusion, increasing the oxygen that's going to mom to then go to baby. So those various things that we can do in that way. And then the variables, it's a lot of position changes to try to decrease that cord compression primarily. So birth procedures, then what are we going to do? What are some of the procedures we might then as nurses be helping with during this labor and delivery process? First would be cervical ripening. So for a woman who needs to be induced, we can't really start contractions. So we're going to talk about inductions, but before an induction can even happen, induction refers to initiating contractions, we have to ripen that cervix if it's not prepared to have those contractions. So there's a few ways we can do this, but it's done depending on a Bishop score. And the table here on the slide shows you this Bishop score. So in the Bishop score, we're looking at the position of the cervix, the consistency, and then the effacement, dilation, and station. A score of 8 or more means that that cervix is favorable for labor. If it's less than that, then the provider will likely do one of these things to help with the ripening of that cervix. So we're going to think about the various types. So misoprostol or Cytotec is inserted in the vagina or taken PO, and it would be repeated every 3 to 6 hours. And the woman needs continuous monitoring if that medication is given. Prostaglandins, such as the two you see in the picture, Cervidil, which is the white string that has the medication infused in it, and then the Prepidil, which is a gel. Both of those would usually be inserted in the evening, and then the mom is monitored overnight at the hospital setting. So to watch for those. So those prostaglandins help to soften and ripen that cervix. It could also be done mechanically with something called a Cook's catheter. So that Cook's catheter would be inserted and then inflated, and the cervix is ripened from a mechanical aspect. Nursing care. So looking at that non-stress test prior to insertion to make sure that baby is doing well before any medication is given. Continuing to monitor that fetal heart rate while the medications are in place. And then especially important is maintaining a supine position with a left tilt for 30 to 60 minutes after insertion of the medications to ensure that they stay where they need to be to begin to work. Labor induction then. So once that cervix is ripe, then labor could be induced. So why would labor be induced? For a variety of indications, including coexisting conditions in the mom, premature rupture membranes, meaning that the membranes ruptured prior to onset of labor. Doesn't mean that this could be a term pregnancy still. This is not the same as preterm premature rupture membranes, which says that it happened early in the pregnancy. Premature rupture membranes just means before labor starts. If there's a fetal demise, if the woman is post-term, or any fetal concerns. So a variety of reasons we might decide to induce labor. Elective inductions, or ones that do not have a medical indication, are not done anymore unless the woman is confirmed 39 weeks or later in the pregnancy. And that does require confirmation of gestational age that was done early in the pregnancy to ensure that the dates are accurate. So how do we do this? So stripping membranes refers to a maneuver that the provider would do to kind of separate the amniotic membranes from the distal uterine segment during an internal exam. And labor sometimes will begin 24 to 48 hours after this. This can be very effective if it's done at the right time and the right person and done well. So is the cervix nice and ripe? Is this person close to ready to go into labor? This can help things along. So there could be some bleeding or bloody discharge afterwards because of the procedure. Other things that can be done, oxytocin. You're going to need to know this medication, and we're going to work on some calculations with this medication. This would be given through an IV and would require some close monitoring of baby and of the contractions. And it's often titrated up until we get the contraction pattern that we want. Complementary and alternative medical options include intercourse. So there are some prostaglandins released with orgasm. There is also some oxytocin released with nipple stimulation, and that can occur in correlation with intercourse or separately. And so those are both very successful ways of causing some things to start. And then you've probably all heard about castor oil being utilized. And so castor oil would be ingested, and that would create some uterine contractions, but it also causes diarrhea. And so diarrhea is maybe not the best thing that you want to have during labor and delivery, so it's not always a great option. At the time of delivery, the nurse may need to assist with operative vaginal deliveries. So these could be for a variety of reasons. Maybe the second stage in the pushing is prolonged. Mom's really, really tired, or there's some medical conditions. These can only be used if baby is very low enough in the pelvis, so low station, to be able to insert these and use these. So there's a vacuum or a forceps, and you see them in the picture, the difference. The goal is the same. So when mom is pushing, the baby kind of comes down, and it's kind of a 2 steps forward, 1 step back. So baby slides down during the contraction, and then they come back up just a smidge in between, and then they come down and then back up a smidge. So the goal really with these devices isn't to pull baby out. It's to keep the progress moving forward and kind of prevent that 1 step back during. So it's really just to hold some consistent pressure and assist the mom through the contractions. Mom's still going to push, she's still going to work through that. The provider's just helping to keep that progress moving forward to decrease that slipping back in between. Some complications that can occur to mom would be she would have to have an episiotomy likely to insert these, or a cut of the perineum to insert these, which could extend. There could be some injury to her pelvic floor, and then possibly some infection or incontinence issues due to some damage to the urethra or bruising. The fetus may have some bruising or edema, maybe some marks from the forceps that are temporary. If baby was large and that was requiring some of this, it could fracture the clavicle on their way out. And then there could be some temporary facial paralysis. But these risks are generally weighed with the benefits of getting baby out in a quicker manner. And so often the benefits outweigh the risks, and that's why they would go ahead and use these devices. As I said, if they're going to use these, they might need to do an episiotomy. So an episiotomy is a surgical incision made in the perineal body to assist with delivery of the infant. And these are not done standardly. Less than 10% of births in the U.S. Utilize an episiotomy. You can see there's two different versions listed in that. Midline is the one that is needed. The mediolateral is really not recommended at all. So midline episiotomy. What we have found is that doing an episiotomy versus allowing that perineum to tear, research does show that it actually leads to more extensive tearing. So they're very uncommonly used, and we allow tearing to just happen naturally if it needs to during delivery. But if pushing is done very well, then it really shouldn't happen either way, because we allow that perineum to stretch during delivery as opposed and kind of control that delivery. So what do we do as nurses? The provider would be doing the procedure. You're really looking at documentation that it was done, and then some care of the incision area after delivery, once it's stitched up. Some of the concerns that we have, especially because it can lead to more extensive tearing, is that closeness. And so you could have a 3rd or 4th degree tear as a result of just delivery itself, or as a result of a episiotomy that then extended into a tear and went further. So the 3rd degree tear partially goes into that anal sphincter, while the 4th degree tear goes all the way through it. And these cause some significant complications following delivery. So those would be some concerns that would need to be thought about. We do know that lacerations also heal more quickly than episiotomies, leaving the laceration the better option for women. Cesarean birth is another option, and this would be done, usually it's about 30% on average in the US. The World Health Organization recommends less than 15% of births should be C-section, but the rates vary around the world, and ours is relatively high in the United States. Some things we have to think about with this is, why is it being done? So maybe the baby's not in a good position, they're not descending into the pelvis, dilation has halted, intolerance to labor or intolerance to contractions, or any medical conditions that would contraindicate labor. Some complications. Obviously it's surgery, guys. There's a risk for infection. There's increased risk for blood clots, which is common after any surgery. And then bleeding is an increased risk. So those risks coincide with any other surgery as well. Things that we have to think about is incision types. So the uterine and the skin incision may not be the same direction, but as far as thinking about what can this woman go forward and have a vaginal birth later on, really is determined by the direction of the uterine incision. So it is important to know that, both at the time of the C-section and making sure it's documented, as well as if she comes back and wants a vaginal birth later on, we do need to know that. Classical is the vertical incision, and low transverse is more that bikini line incision. The low transverse is the common one done now. We don't see as many classical incisions, and the low transverse allows for a future vaginal delivery as opposed to the classical. And again, this doesn't mean the direction the skin incision is, because it could be different. We're looking at what direction was that uterus accessed in. And then anesthesia can occur in a variety of methods. We'll do this practice video to do a virtual one during class time. Some of the nursing care. She's going to need an IV, a Foley catheter, vital signs, monitoring the fetal heart rate, pre-op care, signing consents, all of those things that would occur preoperatively. And then afterwards, you're going to be monitoring that incision, post-op care, coupled with assisting her with that newborn and the normal adjustments following delivery. VBAC, or vaginal birth after cesarean, can occur for those women who choose to try to have a vaginal birth after they've had a C-section. And often what makes a woman a candidate for this is that they've had only one C-section in the past, although some providers will do it with 2. The provider wants to know that they feel they have an adequate pelvis. So depending on, maybe baby was breech and they never even attempted labor, as opposed to somebody who the baby was unable to descend even though they labored for a long time. that reason might indicate that there's not an adequate pelvis. So some reasons kind of for the previous C-section really tell us whether that pelvis was adequate. No other uterine scars, and only that low transverse incision. No uterine rupture. To do a VBAC, there also has to be a doctor and anesthesia in the house should there be some kind of complication during the VBAC that would require an emergency C-section. Nursing care, you're going to want IV access, whether it's with fluids running or just a saline lock, so that you're prepared in case surgery would occur. And then continuous fetal monitoring to make sure that those things are, everything's going well. Risks, the key risk during a VBAC is monitoring for uterine rupture. So meaning that that scar, previous scar, has broken open. Alterations, so things that can occur and what we might do about those during labor. So preterm labor, so less than 36 weeks, 6 days, depends on how early they are. You know, if they're 24 weeks, it's more likely we're going to try to halt labor and stop labor and keep that woman pregnant longer, as opposed to if they're 36 weeks and 5 days, the provider might not be as inclined to stop the progress. Premature rupture of membranes, so those that rupture membranes before onset of labor, and preterm premature rupture membranes. So if they're just premature rupture membranes but they're term, the likely aspect would be that an induction would occur, and as the nurse you would be preparing for that. If they're preterm premature rupture membranes, and again, depending on how preterm, we may be putting her on antibiotics, putting her on bed rest, and trying to prolong the pregnancy and prevent infection as long as we can. Placenta abruption. So a placenta abruption means the placenta has begun to detach before the baby has been born. And this can be a complete or a partial. A partial abruption, we're going to try to get baby delivered as quickly as possible. Complete abruption means that baby has no lifeline. They have no nutrients, no oxygen, and so a complete abruption will often result in a fetal demise or stillbirth. And signs that the placenta is abrupting include a rigid board-like abdomen, loss of fetal heart tones, possibly bleeding, vaginal bleeding, although if it's a partial abruption and it hasn't completely abrupted and the partial detachment is contained in the center of the placenta, you may not have vaginal bleeding. Placenta accreta means that the placenta has started to grow into the uterine muscle, and this may require, the placenta would not detach after delivery, and it may require a hysterectomy. Placenta previa means that the placenta has attached over the cervix, so at the bottom of the uterus. So as that cervix would start to open and dilate, that placenta would become detached. And so that placenta previa means that they have to have a C-section. Because as that cervix dilates, that placenta is going to detach and baby's not going to get what they need. And we can't have the placenta deliver before the baby, so the previa is always going to mean that they need a C-section if it's completely blocking the cervix. Precipitous birth, this just means that everything went really quickly. So sometimes this can create some stresses on both mom and baby because of the fast nature of birth, so just really monitoring for adjustments after delivery. Post-term labor, that placenta may be a little bit aged, so there may be some challenges with that, so monitoring for that, and monitoring baby as a result. Hypertonic or hypotonic labor, so either too many contractions or too few contractions, or not strong enough. So giving medications as ordered by the provider to assist with those, and then monitoring mom and baby because of that. Fetal malposition, you might be doing some position changes if it's an occiput posterior, or if it's a breech, then you might be assisting with the C-section. So depending on what the malposition is would depend on what kind of interventions are needed. If baby is big, fetal macrosomia, cephalopelvic disproportion, we worry about shoulder dystocia. So this means that the head delivers and the shoulders are unable to pass through. And so there's a couple of things we're going to do with that. But the first one is the McRoberts maneuver. So we put the legs way, way back in this maneuver to open up that pelvis and encourage the mom to push. And likely that will free those shoulders. Possibly some suprapubic pressure, not fundal pressure pushing from the top of the uterus, but suprapubic pressure to push right where that shoulder is stuck to try to release it from the pelvis would be the next step that might be done. So the nurse might be assisting in some of those movements to help free those shoulders. Sometimes shoulder dystocia will result in a fractured clavicle in the infant, but again, that heals very, very quickly and is better than the other cases where the baby just wasn't coming out and was stuck in labor. Deliveries were very prolonged in those cases. Abnormal fetal heart tones, and we talked about some of those things you might do during that fetal chop slide. Umbilical cord prolapse. So this means that the cord has come out past the baby's head and is in the vagina or is close to that. So what's going to happen here? So the cord comes out, the placenta is still attached, the cord's just kind of hanging down and looped around, and then the baby's head's there. So as that head comes down, it's going to put compression on that cord and cut off the oxygen supply. So a cord prolapse is an emergency and would require a C-section. The nurse that finds the prolapse needs to stay and continue to put some pressure on baby's head via that vaginal exam to keep the pressure off the cord, and would be having other nursing staff team members come in to help them. Assisting with those lacerations that might occur during delivery, and then amniotic fluid embolism. This occurs when amniotic fluid enters the maternal bloodstream. It's a very rare complication, but it's very life-threatening. So things that you would see with this is she's crashing. If a mom is crashing, this might be suspected. And the crash cart would need to be gotten very quickly. So lots of things that could happen. They're very, very rare. But again, just thinking about the different things that might, how you might need to intervene as a nurse and what your role would be. Thank you for listening today.